Good afternoon, everyone. I'm Tom Glinsky, Chief Inspector with the Board of Pharmacy. I want to welcome you to our webinar today. Today, I have Michael Boger, the Administrator with the Bureau of Narcotics and Dangerous Drugs, also known as Bndd, is here to give us an update. Before we turn it over to Mike, go through just some basic slides with you. All participants are in listen-only mode. If you have any issues with audio through your internet, you can, on your toolbar, gives you an option to use a telephone with instructions there on how to dial in and use the codes to connect via telephone. This has been approved for 1 hour of CE. If you must be logged in to the GoToWebinar under your own username. You cannot listen in under other people and still get CE. If you, there'll be instructions at the end of the webinar if you on how to obtain the CE. Just a reminder that we do not report to the CPE monitor, so everyone needs to be save your certificates that we will email out to you. Handouts, I do not believe handouts are posted yet on the board's website. So right now, the only option is to go to your GoToWebinar toolbar. If you go to the right, there's a section that says handouts, and it should say 1 of 5. If you click that, it'll open a little window up, and you should see a PDF entitled handouts. Those handouts should be on the website later if they're not there yet later, but for right now you can get them off the GoToWebinar toolbar. We do make a recording of all our webinars, and you can find past ones on the board's website under videos and webinars on the news publication and resource page. If time permitting, we'll take questions from participants today, but we are going to start with questions that were submitted in advance. But if you do have a question during the webinar or during our question and answer session, you can go to our web toolbar on your computer, type in the question and hit send, and we will get it. So I'm now going to turn it over to Mike.
Thank you. I'd like to thank everyone for participating in today's webinar. The Bureau always appreciates being invited to come and share information, answer questions, and talk about current topics or issues that people have questions about. So I will go through our prepared information of hot topics that we have that we get questions about, and then we'll open it up for further questions. My disclosure notice. I am an employee of the State of Missouri Department of Health and Senior Services, the Bureau of Narcotics. Our Bureau and myself do not have any financial relationships with any entity in the medical or pharmaceutical industry. We do not accept any honoraria or fees for doing presentations or educational activities. And we do not discuss or get into off-label or investigational uses of any medical devices, pharmaceuticals during our presentations. A list of the things that I've come prepared to talk about today, an update of where we are with establishing the new prescription drug monitoring program, an update on electronic prescribing of controlled substances, updates on telemedicine and what's required of the practitioners. We've been asked to review, again, partial filling of controlled drugs. We've been asked about, is the CDC going to change their opiate guidelines? We're going to talk about doctors wanting to write prescriptions and then have pharmacies send those prescriptions back to the doctor's office so they can use them in the office. We wanted to clarify that. And then we'll talk about how loss reports can be now submitted online, and you can be paperless with that. And we'll get into some the other items. An update on the prescription drug monitoring program. The legislature passed this brand new law last year, establishes Missouri's first statewide prescription drug monitoring program. The state budget is passed in the first week of May each year. This bill was passed in the second week of May, so it was not included in the budget. So the drug monitoring program is going to be placed in the Office of Administration. That's where it's going to be established and housed. They have been seeking approval, securing a funding source, getting permission to spend some dollars on that. The statute requires that they'll pull together a joint task force of physicians, pharmacists, dentists, and a nurse. I believe they've done that. So there are 2 members from the Board of Pharmacy on that task force. There'll be 2 physicians, 1 dentist, and 1 nurse. And they are currently in the process of hiring a manager that will be there day to day to get things established and run things. So I think they've put out the call, they've accepted applications, and they may be in the interviewing process at this time. But that new administrator will be hiring staff, setting up policies and procedures, establishing a website to keep everybody updated on where they're at and what they're doing, drafting regulations. Whoever the vendor is that may be collecting and handling this data, it has to be put out to a public bid. So they'll be doing a public bid to see who the vendor is going to be. That bid process normally takes 90 days. Promulgating new rules can take up to 9 months. That new vendor, once they're contracted, will have to come in, get established, set things up, get all the pharmacies connected. There'll be some educational activities to let doctors and practitioners know how to query it, how to search it. So it might be later on in the year before this is actually up and operational. Once the statewide PDMP is operational, they will then take over the St. Louis County PDMP data. So that county charter was written so that they would have their St. Louis County PDMP database until the state had a statewide one. And then all that data will be moved over. So that's what's going to happen in the future, and that's what they're working on now. I want to talk a little bit about electronic prescribing. This is a law that the legislature enacted, and it's got a lot of exceptions and circumstances to it. And we get a lot of questions sent into the Bndd about this. If you visit our website, at the top of the page, we have a link to electronic prescribing. And at that link, you can read the statute. There's a page that explains everything, provides other information. There are 11 exceptions to the law. So basically, there's a statute that says electronic prescribing of controlled substances shall be mandatory, but then they created 11 exceptions. So pharmacies will continue to get prescriptions every day by writing, telephone, fax. Pharmacies are going to continue to get prescriptions the same way they always have, and that's okay. We expect that. Along with those 11 exceptions for not having to be electronic, prescribers can also apply and get a waiver once a year from the Bndd if they meet certain requirements. Pharmacies are going to continue to get prescriptions every day that are not only electronic, but you're going to get paper, faxes, telephone calls, and you still fill those. You can still fill them in good faith like you always have. If they're legal on their face, they meet all the requirements, you can go ahead and dispense that. Pharmacies in this statute, it specifically states pharmacies are not required to enforce this. Pharmacies have immunity. The pharmacist does not have to know which doctors should be electronically prescribing and which ones shouldn't, and which ones have a waiver. The pharmacist doesn't have to know that, and it's not their responsibility, and they have immunity. The job to know whether or not doctors should be electronically prescribing, that's enforced by the licensing board. The statute says that if practitioners are not electronically prescribing as they should be, they are subject to discipline by the state licensing board that licenses it. So that's kind of where we are in the state of Missouri right now. Pharmacies, maybe you're going to see an uptick and an increase in electronic prescribing, but depending on where you are in the state, broadband availability, you're going to continue to get prescriptions the old routine way, and that's okay. Telemedicine has kind of been a hot topic because of COVID and being able to see and treat patients remotely. And the state of Missouri has some statutes on what's required in telemedicine. And then the DEA and Congress put some more laws that are even more restrictive for controlled substances only on that. Telemedicine's been around for a long time. It's been going on for years. And doctors are seeing their patients remotely, and they've been prescribing for them, but they've been prescribing non-controlled drugs. They weren't allowed to do controlled substances through telemedicine. Later on down the road, when they approached the DEA and they wanted to be able to prescribe controlled drugs, a lot more stricter laws were put on that, but just for the controlled substances. So these are not DEA regulations. These are laws passed by Congress. So if people aren't happy with the laws, they're going to have to go to Congress and change them. It's not a rule that the DEA can change. But looking through the laws as they stand right now, Chapter 334.108 is the statute that determines that physicians must have an initial face-to-face in-person physical exam before they're going to prescribe any drugs by telemedicine. There has to be that initial face-to-face in-person physical exam, and that statute describes that. The telemedicine communication must be in real time with face-to-face video and audio. They just can't use a telephone or some other device. It has to be both audio and video, and it has to be in real time. According to the DEA, the practitioner must have a medical license and a DEA number in their home state where they are located, and then they have to have a license and a DEA number in every state where they are seeing a patient by telemedicine. So if they're only seeing patients in their state, that's fine. But if they're crossing a state line, they have to have separate licenses and registrations in every single state. Location is a very big deal under this statute. The DEA law says that patients must be located in a DEA registered facility when this telemedicine takes place. They need to be in a hospital, a surgery center, or some other type of licensed facility that has a DEA number. If the patient is not in a DEA registered facility, they could be in a doctor's office or a clinic, but they have to be in the presence of and accompanied by a DEA registrant, such as the doctor or a mid-level practitioner. That means that patient has to leave home. They have to come in somewhere to be seen. So they're either going to be in a hospital, a surgery center, or a registered facility, or at least they're going to have to be in a doctor's office and have a doctor present with them. And of course, to me personally, I thought that kind of defeats the purpose of telemedicine if you can't see somebody while they're sitting in their house. But when I double checked this and I spoke with some of the group supervisors in the DEA, they told me that it was never the DEA's intent to let patients just sit at home and Skype and see their doctors on a laptop or a phone and get controlled drugs that way. They wanted to expand healthcare and people's availability to see specialists or experts. They wanted people in rural communities to be able to reach out and have their doctors consult with experts in larger places, like the Mayo Clinic, or people in rural Missouri that want to consult an expert in St. Louis or Kansas City. So that's the thing. When we have doctors call us and tell us, well, I want to prescribe for my patients, but they're at home, they can't do that with controlled drugs. So for controlled drugs, that patient has to come in somewhere, and they're either going to be in a DEA registered facility, or they're going to be in a doctor's office where there's a DEA registrant with them. So that's where we are right now. We have some doctors from out of state, and they're going to need a Missouri Bndd number in order to do telemedicine here. Well, what address do they use? Well, we're going to tell them use the address where the patient goes, because that's where their chart's going to be, and that's where we can call and ask questions. So right now, and we don't know how long this is going to last, the DEA has a temporary COVID waiver. It does allow a patient to be at home and not be in a hospital or clinic. We still require the doctors to be registered with us, but eventually, as everything else, the state of Missouri has ended all of our COVID waivers. So at some point in time, people have gotten used over the last 2 years of the COVID waivers, but when they go away, we are going to be telling patients, you can't be at home, you have to go into the doctor's office or a hospital. And I'm sure that may not be a popular decision that they're going to hear, but it's a federal law. I was asked to clarify and go over this next item, just a review partial filling of controlled substances, partial dispensing. And basically what our rule is in a nutshell, you would partially dispense for basically 2 reasons. One is if you're just low on drug supply and you don't have enough drug that day. And the second is at the request of the doctor or the patient. If the pharmacy doesn't have the full amount because of short supply, you must try to make the remainder available within 72 hours. If for some reason you cannot make the remainder available in 72 hours, you need to notify the physician. They can write another prescription and the patient can try to get the remainder somewhere else. But that's what you do if you are only going to partially dispense because your supplies are low. The second reason you can partially dispense is if it's at the request of the doctor or the patient. Sometimes the patient doesn't want the entire dosage all at once, or maybe they can't afford it. Maybe the doctor doesn't want them to have a full supply all at once and they spread it out. So they can write me a prescription for a 90-day supply, and then they can tell on the instructions they only want me to have a 15-day supply at a time, and I'm only supposed to have 15 days at a time. That means I'm gonna have to come back 8 times. Those partial dispensings do not count as an entire refill. So, a refill would be if you dispense the entire prescription all at once, but partial dispensing doesn't count as a refill. So if I'm going to get 90 pills and I'm going to get them 15 days at a time, I can come back 8 times. Schedule 2 can partially be dispensed for 60 days. Schedules 3 to 5 can be partially dispensed for up to 6 months. I was asked about the CDC maybe looking at updating and putting out some new opiate prescribing guidelines, and would those be enforced by the Bndd or the DEA, and would we take those new limits on? And our response to that guideline has always been the same. The CDC published opiate prescribing guidelines It was an educational tool to assist practitioners, to allow practitioners to read more about it, study more about it, learn more about it, get some advice, have some guidelines. It was not a statute, and it was not a regulation, and it was not enforceable. So although the CDC put out an educational guideline of suggestions, they don't carry the force of law or regulation. And the Bndd and the DEA can't run around and cite somebody out because they prescribe more than what the guideline says. So determining quality of care, proper clinical care, is a peer review issue that goes to the state licensing boards. So if somebody thinks that a patient is getting too much too soon, that needs to go to the state board for peer review. The Bndd and the DEA don't have physicians that can go tell a doctor you're misprescribing, overprescribing, things like that. So if the CDC does change their educational guideline, it's really not going to impact the Bndd because it doesn't carry the force of law. We've had a change in Missouri statute about doctors taking back patients' prescriptions. And I wanted to clarify this. And we've been discussing this and putting this out not only to the prescribers, but I wanted to make sure the pharmacists were clear on this, because there's the old law, there's the new law, and I don't want our doctors to misread this and get into trouble because they misread it. So the DEA still has a regulation on the books that says that when doctors want drugs in their office to administer or dispense, they buy those through a distributor or manufacturer, and they stock their own drugs. Doctors cannot write prescriptions in order to get stock for their office. And that is still a regulation that the DEA has that's current. The Missouri legislature took that and made it into a statute. And our old law matched that DEA regulation. And our law actually said that a practitioner cannot accept or take back or take possession of a patient's controlled drug prescription for any reason. So we don't want patients taking their drugs back to a doctor's office. That lets doctors have drugs in their possession that are unaccounted for, off the books. We don't know what they're doing with them. They can be diverted, abused, stolen. They share them and hand them out to other patients. That's why this statute was in place. And then times changed. Of course, those laws were written in 1970. Times change. There are some times when a patient does need a drug and it needs to be administered in a doctor's office. We don't want them to take it home. So the DEA has some exceptions. So although they have a rule that says you can't do this, they have an exception to policy. There are now 2 times that we are aware, 2 instances of where you can write a prescription, the pharmacy can fill it, the pharmacy can deliver it to a doctor's office, and the doctor administers it to the patient in the office. The first one is injectable buprenorphine products could be sent to one of those doctors that is an opiate treatment provider, has the X on their DEA number. If they've had the training and they have an X number on their DEA number and they're doing office-based opiate therapy and they want to provide buprenorphine or Suboxone products to their patients, if they write a prescription for injectable buprenorphine, that prescription can be delivered back to a doctor's office so it can be administered in the doctor's office. The DEA's even published that is in their pharmacist manual. So that is acceptable. And then we are aware of another exception where the DEA has given permission for a drug called esketamine. The brand name is Spravato. That can be sent to a doctor's office for administration. It's my understanding that drug has some ketamine in it. It's also in humans a little bit of a hallucinogenic. It's used in treating depression, suicidal behavior. They've had a lot of success with it, but because it's a hallucinogen, they want it to be administered in a doctor's office, and they want the patient to be observed for 15 minutes before they're allowed to leave. So that's a situation where the FDA and the DEA agreed that the doctor can write a prescription. Pharmacies can send that to a doctor's office. It's going to be administered there. They're going to monitor the patient before they're allowed to leave. So that's the second exception where doctors can stock and use patients' prescriptions. These are the only two drugs that we are aware of. So now that means we need to update our Missouri statute. We're going to start having exceptions. The Missouri legislature did not want to change the law every time the DEA comes up with a new drug. We don't know what new exceptions are going to be coming out in the future. The DEA could issue exceptions a lot, and we don't want to have to rewrite our statute every time. So we just kind of did a blanket. Missouri went in and amended our law in section 195.070, and it said that practitioners can issue a prescription, and they can only have that prescription returned to their office for administering, and then the key phrase is, as authorized by federal law. So that lets us say, if the DEA allows it, Missouri allows it. And that way, we are in lockstep together and we match. If it's okay with the DEA, it's automatically okay with Bndd. So all we need to do is we need to make sure the doctors know that if they're going to do this, they have the DEA's permission, and it's a drug that they're okay with, they can take possession of before they bring it back to their office and use it. So doctors asking us what drugs can come back, pharmacies asking us what drugs can go to a doctor's office that are prescribed. Bndd is going to do whatever the DEA allows, and the DEA right now allows those two drugs, injectable buprenorphine and the Spravato esketamine, and that's it. And we wanted to go over that because I don't want a doctor to read that statute that I can have drugs returned to my office and then they're starting to do testosterone or opiates or amphetamines or something like that. That key phrase is they can do it as authorized by federal law. I wanted to give everybody an update and let everyone know that if and when you would have a situation where you need to do a loss report with the Bndd, in past years and past times, you would go to our website, fill out a form, and then you would mail it or fax it in. Now you can go paperless. Now when you go to the Bndd website, there's a link there. You can click on a link to just report your loss report electronically. And you can check a box, whether it's initial report, a final report, it's fill in the blank, you check boxes, you fill in the blank, and you just submit it, and it'll arrive to us electronically. And you have the ability to save it, you have the ability to print it, it's assigned a number. You will have the ability, if you wanted to go back in and amend it later. So if you find out something was different, you want to make a change, you can go back in and amend the document that you submitted. But if you would like to go paperless, you can certainly do that. Now, we want to, yeah. Some other items that came in that I was asked to mention after we got the slides prepared and everything. The DEA is reviewing their rules on transferring controlled substance prescriptions. When can they be transferred? How many times? What if they're electronic? What if the two pharmacies are owned by the same company? Bndd does not have a specific regulation on transfers. We refer to the Board of Pharmacy on that and whatever the DEA has in their rule. So when it comes to transferring prescriptions, we would go with what the board allows and what the DEA allows. So if the pharmacies are following their existing regulations, they're compliant with Bndd. Another topic that came up is from time to time, we have a patient that comes to the pharmacy counter and they want to buy Sudafed. And when they get into the NPLEX database, the Sudafed system, the sale gets declined. And the patient doesn't know why, and they get upset. And we had a mechanism in place there for them. And what that is that if they can note, the date and the time, what pharmacy were they at, that there's usually a transaction number that got declined. Let them know that transaction number. There's a toll-free number that the patients can call the database, and the database people will talk to them and tell them why they're declined. And I'm going to give you that number, and I'll give it to you a couple of times while you're grabbing pens, but it's 888-520-6384. And we've also put that information in our Bndd newsletter that's on our website. But we knew that at times patients would get declined, and then they would be unhappy and they'd want to know why. We didn't want to put that burden on the pharmacist to make a pharmacist have to argue with the patient. The system's just going to say declined. And if the patient wants to know why, you can give them the time, date, the transaction number, give them this toll-free number, and the patient can deal with the database people if something needs to be changed or fixed. But that toll-free number again is 888-520-6384. And then I had somebody ask Bndd about this past year or so, we've had that statute on the 7-day limit on the initial opiate prescribing. On the first time new acute care injuries, doctors are limited to a 7-day supply. And they wanted to know the impact of that statewide and how that's changed things. And my answer to that is, we don't know, because we don't have a statewide PDMP. We just know that before, maybe those patients were getting a 10, 20, or a 30-day supply. Well, now they're only getting a 7-day supply, and they have to have another consultation before they can get more. Are they getting more? Are the doctors doing it? I know that over the past couple of years, opiate prescribing's down. We're seeing less prescriptions for opiates, and those prescriptions are for lesser amounts. So the prescribing is down overall in the state of Missouri the past couple of years, but I don't have hard data without comparing through a prescription monitoring program. If you want to contact the Bndd for any other future things, if you don't get your question answered here today, email is most efficient. Email us at our email address provided there, bndd@health.mo.gov. We don't have to play telephone tag. If you ask a question, we'll look it up, find that regulation, email it back to you. I give you our website there, or you can just Google Bndd and we'll be the first one that pops up because we get the most hits. But from our website, you can apply for registrations, change your registration, review our practice guidelines, statutes and regs, newsletters, forms, things like that.
Okay, thanks, Mike. Before we get to questions, there was one slide I wanted to talk about. It's the Safe at Home Opioid Patient Safety Initiative. This is part of the board's RX Cares program, and this is one of the components of that program. And it's a coordination between the Board of Pharmacy, MoHealthNet, and the Department of Health. And the board is providing some of the funding for this. And MoHealthNet will now pay for the dispensing of DisposeRx packets for MoHealthNet participants. DisposeRx packets are little packets that powder that a patient can, if they have a bottle of medicine that they want to destroy at home, they're able to pour this powder into the vial and then add a certain amount of water, and then it will it inactivates, and I'm not sure how all it does it, but it turns it unusable, and then the patient can throw that away. So it'll be a way for patients to dispose of drugs at home. And so MoHealthNet will pay for the packet and a dispensing fee. For this, MoHealthNet put out a provider bulletin a month or so ago about this. The Department of Health created a statewide standing order. It's under Dr. Turbulese that a pharmacist could use to create a prescription under Dr. T's name in order to bill Medicaid for the packets. The standing order, you need to read it. It has guidelines on how many packets. It's either 1 or 2 based on the vial size of the prescription. You follow that. And then another option would be if the patient's own practitioner writes a prescription. If they're a MoHealthNet prescriber, you could fill that under MoHealthNet and being reimbursed for it. There is a mandatory requirement for the dispensing of these packets that counseling must be required. It must be conducted covering 2 topic overdose risk factors and the proper use of the DisposeRx packet so the patients understand how to use that. So there's more about this program on the board's website under our RX Cares page. There are links to more information about this, the standing order, and MoHealthNet's provider bulletin on this topic. Okay, so we're now going to move to questions, and as I said earlier, we're going to start with those that submitted them in advance. Some of them Mike has already addressed in his presentation, so we're not going to answer those. We're going to take ones that weren't addressed today. So let's see, first one, are pharmacies required to verify the prescriber has a valid Bndd with each prescription, or can the pharmacy assume if the provider has a valid DEA number, the prescription is legitimate, assuming there are no other red flag indicators?
Yeah, we get that question a lot, and one of the other questions that was even posed talks about a gray area surrounding the Bndd, and how often do pharmacies have to check that? The federal law says that you should make sure the prescription has a DEA number on it, and the state law says that a prescription has to have a DEA number on it. There's no law that says a prescription has to have a Bndd number on it. No doctor is required to put their Bndd number on a prescription. So the pharmacies are voluntarily, randomly checking Bndd registrations as they feel fit in their judgment of what makes them feel comfortable. They don't have to verify a doctor has a Bndd registration, but you can do that on our website. You can go to our website, type in any practitioner's name and search, and if they're currently registered, it'll pop up there. So if you have new doctors, new prescribers in your area, and you want to double check, you certainly can. But we don't have a law or a rule that requires you to check or tells you how often to check.
Okay, we have someone asking about basically medical marijuana, and how does the pharmacy handle that if one of their employees tests positive on like drug screen while having a prescription for it? I think they're asking, does Bndd have any advice on how to handle that?
Early on, when they started medical marijuana, and we knew there would be citizens out there with marijuana in their system, that made a lot of our medical providers uncomfortable. How are they going to handle that? Because now they can legally go get a medical marijuana card and buy marijuana at a store and have it and consume it. And that's legal within the law. Now, the question is, and this is totally different, are they allowed to go to work and perform their job at work while under the influence of that? And all the employers that I know of, they get to make their own policy. because a person might have a medical marijuana card and they might go get medical marijuana and consume it, but then you don't want them flying your airplane. So employers have the right to make their own policy. Do you want your employees to show up at work during the day and be under the influence of marijuana? So what a lot of the employers did was they brought up their alcohol policy. What's your policy on employees showing up for work with liquor on their breath or under the influence of alcohol? They took their alcohol policy and they just crossed out the word alcohol, entered the word marijuana, and that way they have a policy. So I guess it's up to you, the employer. You can have a policy that says, while you're at work, I don't want this influencing your system. And what you do on your time off, your days off, is your business. But when you're at work, you can't be doing this. We do that with alcohol. I think you can do that with marijuana. So have a policy and you can follow it.
Okay. Can controlled substance prescriptions be dispensed per chart order for long-term care facilities?
Okay. That is a tricky question that we get asked a lot, and we talk to the long-term care facilities about this a lot. There's a difference between an order and a prescription. A prescription is something that has to go to a retail pharmacy, because by law, only a pharmacy can dispense prescriptions. So when you say prescriptions, you're talking retail pharmacy has to dispense it. An order is just when a doctor wants a patient to have some drugs and the drugs are already there. The facility owns the drugs and they're just telling the nurse, go pull this out of the machine and administer it right now. They're administering it right now immediately. They're not giving the patient a supply for the future. It's for direct administration. So orders are given to patients in a hospital. Prescriptions go out to a retail pharmacy. Now, the thing about nursing homes don't have a pharmacy inside them. All of their patients get their drugs from prescriptions. They see their doctors. The doctors write prescriptions. The facility gets them filled. Those medications are brought back to the nursing home and stored there. And then the staff dispenses them and administers them according to what's written on the prescription. So really, in a nursing home, they're getting their drugs from prescriptions and it's not an order. So when the doctor calls up and says, I need for a patient in a nursing home to have some drugs, they got to write a prescription. And then the pharmacy will fill it. It'll go to the nursing home and their staff will dispense it as directed. When we go to the nursing homes and we inspect them, there needs to be prescriptions, and that's how they get drugs. The staff gets confused. They use the word order. Whenever the nursing home and the doctor send that request to the pharmacy, it needs to be a fully legal prescription. We have a lot of nurses say, we're going to send an order in and ask for an order, or send an order to the pharmacy, and they'll fax or send over a piece of paper that says, we want patient Mike to have 1 Ambien a day. That's not good enough. They got to write a prescription, have it signed. They got to send it over. Now, whether it's faxed, electronic, delivered, but it's all prescriptions. So that's the difference.
Okay, next one deals with fax prescriptions received by the pharmacy. If the fax doesn't have a banner identifying the sender phone number, is that compliant? And then is a cover page sufficient?
Yeah, we want to know the information of who sent it or where it came from. So if it's got the banner at the top that gives you a phone number, a time, or something like that, who sent it, that's fine. Sometimes if it doesn't have that, if it's got a cover sheet, that would work also. We would accept a cover sheet that identifies the sender.
Let's see, this is about storing outdated C3 through 5s. Can they be stored in a separate area that is not dispersed with non-controlled substances?
Yes, they can. You do not have to keep your expired drugs out on the shelf with your end date drugs. You can move them out and separate them, but they have to be locked up in a safe or a cabinet. We know that the pharmacy is going to have all kinds of scheduled drugs, and the Schedule 2s are locked up in a safe or a cabinet. The 3s and 4s and 5s don't have to be locked up if they're scattered and dispersed among all the other legend stock. But if you're going to pull out the expired drugs and separate them and move them off and store them separately because they're expired, then they have to be locked up in a safe or a cabinet.
This is a question about a take-back receptacle. How does a pharmacy handle moving one to a new address, or if there's a change of ownership with a pharmacy who has a drug take-back receptacle?
Just let us know about it. Let us know what change you're going to make, and then we can assist you with that change. So if you're going to move a box out of your pharmacy and put it in a new pharmacy, make sure that new pharmacy has authority, that they've talked to the board, that they've let the Bndd know, and that they've got the DEA approval. If you're going to change your address, let us know, because we'll have to issue you a new registration. If you're moving your entire pharmacy, we'll want to update that. And then we know you would be taking, your box with you. But if you need to move a pharmacy, move your box, that's just changing an address. Let us know, update us, and we can do that. But you have to let the agencies know.
Okay, so our most common questions submitted in advance were had to do with dispensing of testosterone vials, and we had lots of questions on please explain how to properly do that.
Yeah, because a few years back they changed the way that they were packaging it, and they're more 10 milliliter vials, less 1 milliliter vials. Prescriptions, you would like to be able to dispense them the way they're prescribed, but there's limits. The maximum that you can dispense at any one time is a 90-day supply. So based upon the directions of use, and you look and see what the patient's going to be administered and how often, you look and see what it's going to take to get them through 90 days. That's the maximum you can give. We've had some questions about the patient's going to use 1 milliliter a month, but the pharmacy gave him 10 milliliter vial and said, waste the other 7. Well, you can't do that. If you give them 10 milliliters, you're giving them a 10-month supply. And we equate that. If the prescription was for 40 pills and you gave me 100 and said, well, waste the other 60, you wouldn't do that. So it's the same thing here. Look and see what they're supposed to take, how often, and then you can calculate it out. 90-day supply is the most that you can dispense at any one time. And there's differences there. The doctor could change their prescribing. There are availability out there. We've seen 1 milliliter vials in the pharmacies. If you're a compounding pharmacy, you could repackage it. We've also got more doctors now that will just buy the testosterone, they stock it themselves, and then when the patient comes in, they can just give them an injection. So we're seeing different ways around that.
Okay, I could just clarify on the compounding pharmacy, you would be a sterile compounder if you were doing that. So that would be extra board rule that would apply and be Class H on the license. Okay, let's see, we had a question on how far away do pseudoephedrine products have to be from reach of the public if they're behind the counter?
Controlled drugs kept behind the counter, how far? My answer immediately is out of reach. I know it gets crowded up there around the front, around the cash register and everything that's up there. And normally the Sudafed packages are just right there behind the pharmacist, within reach, pretty close somewhere. As long as they're from behind the counter and the public can't reach them, you know, and that's for all drugs. If any customer can walk in and reach across your counter and grab any drug, it's too close. So if they're out of reach and they can't get to it, then that would meet our standard for that Schedule 5 Sudafed.
Okay, someone's asking about no longer required to print prescriptions and use a 3-file system. So this is more of a board question, so I will address it. Yeah, the board does allow imaging of prescription hard copies if it's done in compliance with the board's imaging rule. However, when it comes to controlled substances, the DEA still requires a physical hard copy for everything except e-prescribed prescriptions. So, so for the control files, you still will have, even if you're imaging, you would still have hard copy prescriptions for all controls except e-prescribed, which you're allowed just to use an image. The board still requires an image for any e-prescribed prescription. Our practice guide has a couple sections in there about hard copy prescriptions and the image requirements if you have questions about that. And then we had one come in early this morning on, can you explain what a medical reason is for a 90-day supply? I understand diagnosis code is not acceptable, but what actually is?
That is a great question, because when the Missouri legislature wrote that law, they of course knew that Schedule 2 prescriptions are normally for 30 days. You can go over 30 days up to 90 if the prescriber writes the medical reason on the prescription. They didn't define medical reason, so we really don't know what they want or what they intended. They just kind of left us hanging. So what we're looking for is, we want the doctor to let the pharmacist know we're giving them an extended supply and here's why. And they'll normally put down the diagnosis and the status of the patient. The most common thing we see is stable ADHD, those two words, stable ADHD, or we'll say stable chronic pain. Sometimes the doctor might write a little bit more. They need to write it in English. A diagnosis code's just not enough. The doctor can't write a prescription and then put down 37,418. That doesn't tell anybody anything. But if you know what the patient's being treated for, that they're being seen, what's their condition, that's what we normally see. The doctors are writing something like that. The diagnosis, the patient status. Stable ADHD is the #1 thing we see every day. And if for some reason the doctor doesn't write it, you can call them up and ask. It's one of the things you can add. You can make a note. You call the doctor. Whatever they said, you can write that down. You can add it.
Okay, so we'll switch over to some of the questions that came in during the webinar now. So we have someone asking, is Bndd concerned about physicians that are writing for a lot of phentermine at this time of the year?
Bndd's concern is that there isn't illegal activity and diversion, things like that. Now, the question there is what the doctor doing legitimately within their scope of practice? Is it good medicine? That would be a board issue. We have seen doctors prescribe phentermine for weight loss. We can go to the pharmacy and get a printout of those prescriptions. We can go to the doctor's office and verify that he's actually seeing these patients and is weighing them, charting their weight loss, has a chart on them. And as long as the doctor is doing all those things, he's obeying Bndd law and DEA law. It would be the Board of Healing Arts to decide, is this really an appropriate therapy And is that a proper amount? In the past, I will tell you this, when Bndd finds doctors not using phentermine appropriately, is when they're not prescribing it, they're buying it themselves and they're stocking it and they're dispensing it and handing it out. And then before you know it, maybe the office staff is taking it, the receptionist is taking it, the nurses are taking it. They're supposed to have 1,000 on hand and they've got none. A lot of Bndd's phentermine cases are when doctors are buying their own phentermine and trying to dispense it themselves. If the doctors are prescribing it, then it might be a quality of care issue. There's been a change in the law over that, where if the doctor's going to prescribe phentermine for a long time, they expect to see weight loss. Now they've backed off of that. Sometimes now a person's taking phentermine just to maintain, and the weight loss might be slower. So the board has changed the way that they used to call it the old amphetamine rule, that they actually did away with several years ago.
On a similar note, someone's asking, how often does Bndd inspect doctors, especially those that get reported as questionable?
Okay, that's a good question, because first of all, reported as questionable, if we get a complaint, we will go in. If we get a referral, we will go in. So I will tell you that when we get a complaint, when somebody tells us we need to go look at somebody, we inspect 100% of those. We will always go on those inspections. Other than that, how often does a doctor get inspected? Well, I've got 33,400 registrants, and I've got 6 investigators in the field. The chief investigator and I could also go out and do something like that. So we've only got 8 people that could possibly do an inspection. 6 are doing it all day long, full time. So they're doing about 1,400 random routine inspections a year on top of all their other investigations and other stuff that they're doing. They do 1,400 or so random unannounced inspections, and that's with everybody. They're doing ambulance buildings, hospitals, nursing homes, veterinarians, dentists, everybody. So yeah, there's a possibility, if you do the math, you could practice in Missouri your whole life and be a doctor and retire at the age of 70 and maybe never get seen by the Bndd. But we don't have enough inspectors, and there's a lot of registrants out there. But if something comes up and something's brought to our attention, we will always go 100% of the time.
We got some e-prescribing questions. Here's one on about nursing homes requiring physicians to write paper prescriptions, and then the nursing home will deliver them to the pharmacy. Is that acceptable under the e-prescribing mandate?
Yes, because the patients are in a nursing home. That's their residence, that's their home. They have to have prescriptions. So somehow, some way, that prescription has to be delivered to the pharmacy. It also has to be put in the patient's chart at the nursing home. So if the doctor is writing prescriptions, the nursing home may be photocopying them to put in the chart. The nursing home can deliver them to the pharmacy so that they can be filled. One of the exceptions to electronic prescribing is if they don't have the technology. If you don't have the broadband, if you don't have the technology, or if you don't have a financial situation where you have electronic prescribing yet, you get a waiver. So it could fall under that too. If the doctor's making rounds and the doctor's writing prescriptions as he goes through the nursing home, they don't have the ability to electronically transmit that. The nursing home doesn't have it. They're going to have to then fax or hand deliver prescriptions.
Okay, well, we're out of time, Mike. You got a lot of questions that came in. Can people send those to your email address?
They can email bndd@health.mo.gov, and we'll shoot them an answer.
Okay. Okay, so before we close the webinar, We do make a recording. It could take up to 15 days before it gets posted on our website. We have one from earlier this year on the COVID-19 posted. For continuing education, you must complete the post survey that will pop up on your screen after I close the webinar. So do not close your browser. You will get a little window that says I've ended the webinar. Click close on that, but again, do not close your browser, and a survey screen will pop up. Answer the questions and click submit. If that does not happen for you, you can email us at compliance@pr.mo.gov. Ask us for the webinar questions and we will email them to you. You must get them back to us within 24 hours in order to be considered for CE. And again, we now email certificates. It can take anywhere up to 30 days, so watch your email for your certificate. So I want to thank Mike again for coming today and giving us an update, very informative. And I want to thank all of you for attending the webinar today. I'm now going to close the webinar.